Good morning and welcome to my talk on oncologic emergencies. Oncologic emergencies come in two varieties, those caused by mass effect and those caused by evil humors. Mass effect is caused by an expansile mass in a non-expansile space. Generally speaking, Mother Nature encloses the most important parts of the human body in a bony cage for protection, so that the brain, the spinal cord, the heart and lungs are all surrounded by bony cages. The second line of defense with Mother Nature is duplication. So you have two eyes, two ears, two kidneys, two ovaries. So examples of mass effect are spinal cord compression, superior vena cava syndrome, cardiac tamponade, and increased intracranial pressure. I'm going to talk about spinal cord compression first. Spinal cord compression occurs in between 2 to 5% every year in patients with what are considered to be incurable malignancies. 61% of spinal cord compression is either lung, breast, or prostate in origin. Multiple myeloma alone accounts for 11%, and never forget that lymphomas can lead to spinal cord compression. Spinal cord compression is seldom lethal in its initial presentation unless it's above C5. C5 innervates the diaphragm, and obviously if the diaphragm stops working, the patient stops breathing. But most spinal cord compression is below this level. Untreated spinal cord compression, however, has a major impact on quality of life, and it leads to relentless and progressive pain, paralysis, sensory loss, and sphincter dysfunction. This is the bony cage that's provided by Mother Nature. You can see the vertebral body at the top part of the picture with the hole in the middle where the spinal cord rests. The posterior elements form the rest of the bony cage. The ependymal cells in the brain secrete CSF, which goes into the ventricles and then washes over the brain, goes down the spine, buffering the spinal cord, and is reabsorbed in the cauda equina. As you can see from my crude drawing, the spinal cord is surrounded by CSF in the left-hand picture, which is supposed to be a normal spine. In the right-hand picture, when you have involvement of the vertebral body, you can see that there is no CSF as it's compressed out of the area. This can be seen on plain films, which we seldom do anymore, where you have missing facet joints. This, you can see where that little tiny arrow is. There's supposed to be a round white thing, which is a facet joint, and you can't see it there. The picture below shows a CT scan, which shows involvement of both the lateral element and the vertebral body and compression of the cord. The best way to visualize spinal cord compression and the modality that we use to diagnose it is MRI. And in this picture, which is a lateral view of the lower thoracic and upper lumbar spine, you can see that there's spinal cord compression at L1. The dark line that's surrounded by two bright lines is the spinal cord. The bright lines on either side of it are the CSF. You can see that there is a bulge which compresses the spinal cord at L1 and obliterates the fine white bright lines of CSF. Symptoms of spinal cord compression are pain, pain, and pain. It's usually pain completely out of proportion to the physical findings. The patient comes in, they have no physical findings at all, and they just have terrible, terrible back pain. The neurologic symptoms that are oftentimes seen are constipation, urinary frequency, weakness, numbness, or hyperesthesias. The urinary frequency is due to urinary overflow from an atonic bladder, and the patient usually comes in saying, I have a bird bladder, doctor, every 15 minutes I'm leaking urine. The neurologic findings have to do with where on the spine the compression occurs. The findings are showing no response, no function below the level of compression. So the diagnosis of spinal cord compression is, first of all, you have to be suspicious, and you do an MRI for anybody that you are suspicious. When somebody with metastatic prostate cancer comes in and they have back pain, you have to assume that they have spinal cord compression. We oftentimes start them on steroids because it helps decrease inflammation around the cord, and send them for an MRI. So the treatment of spinal cord compression are steroids, not because they actually get rid of the spinal cord compression, but they decrease the inflammation and get you a little bit of space around the cord, thereby alleviating some of the compression. The actual therapy is either a stereotactic radiosurgery, conventional external beam radiation therapy, or surgery. So determining the proper therapy for spinal cord compression is important. And we use the NOMS, N-O-M-S scale these days to help us determine what the proper therapy is. As you can see, we have some drawings below of the vertebral body and the posterior elements. And you classify how much compression by where exactly the lesion is and how much it impedes or imposes on the spinal cord. Using how far in it impacts the spinal cord, and then combining that with symptoms, how radiosensitive the tumor is, how stable the spine is, and how well the patient is, you can decide using this chart whether or not the patient should have separation surgery, stabilization, stereotactic radiation surgery, or full radiation therapy. There are a number of reasons for surgery, and I'd like to discuss them now. So patients who have an unknown primary, if a patient comes into the emergency room and they've never had a diagnosis of cancer, and they have spinal cord compression caused by what looks like a cancer, and you do a CT scan and there isn't an obvious source found, like there isn't a big lung lesion, there isn't a breast mass, there isn't a mass in the pancreas or the prostate, those patients need surgery, because without surgery you'll never know what the cause of the spinal cord compression is, and you won't be able to render the proper therapy. Patients who have spinal cord compression in an area that's previously been irradiated need to have surgery. The spine has a very low tolerance for radiation therapy, and you can't come back in and irradiate it. Generally that causes radiation myelitis, which causes spinal cord failure, which gives you the same symptoms as spinal cord compression, and therefore it should be avoided at all costs. Patients who progress during radiation therapy, who have very resistant tumors, those patients should go for surgery. Patients who have unstable spines should go for surgery. People who have the abrupt onset of spinal cord compression usually need surgery. The patient who rolls over in bed, feels a pop and can't move their legs, is a person who almost certainly has bony retropulsion into their spine and compressing their spinal cord. Radiation therapy is not going to remove the piece of bone that's pressing on their spine, and those patients need surgery. Patients who have radio-resistant tumors oftentimes need to go directly for surgery. The radio-resistant tumors tend to be the renal cell, melanoma, colorectal cancers. Those don't tend to respond very well to radiation, so we oftentimes go with surgery first with them. In 2005, Patchell published an article in The Lancet, and he also gave the plenary session at ASCO, and I have to say that it was like a revival hall meeting, because people were so excited at the data that he presented. He did a study at the University of Louisville where he randomized patients. He's a neurologist, and he worked with the neurosurgeons and the radiation oncologist and managed to get a study through their IRB where patients who came in with spinal cord compression would randomize to either surgery first or radiation therapy first. And then he followed them. The study was terminated early because it reached early stopping rules where the surgery was shown to be better. The patients who received surgery maintained their ambulation better, 84% versus 57%. They ambulated longer. They ambulated for 120 days versus 13 days. So they basically ambulated until they died of their metastatic disease. Urinary continence was better in patients who received surgery, and they had better functional status. And if you look at the p-values on all of these are not insignificant. These are very significant p-values. In addition, and this was not looked for, but it was found, the patients who underwent surgery had an extra month of life, and this was unexpected finding. So most everybody who comes in with spinal cord compression should be seen by the surgeons, either the neurosurgeons or the orthopedic surgeons, depending on what service in your hospital deals with tumors in the spine. So there are various different surgical alternatives. There's radiofrequency ablation, where they use radiofrequency waves to pass through the tumor. There's balloon kyphoplasty, which is a minimally invasive treatment that's done under local anesthesia, which restores the height to the vertebral column. There's separation surgery, where the spinal column is stabilized and the epidural tumor is resected just enough to restore the white lines on either side of the spinal cord on an MRI, which allows the patient to undergo stereotactic radiation therapy, which is more specific and less toxic. The radiation, there are 3 different kinds. There's a short course, which is just 1 fraction. It's for poor prognosis patients. The reason we use it is because the long course, which is 2 weeks of patients coming in and out every day, can be very difficult for a patient who's in really bad shape and perhaps is coming and going via ambulance. The reason that we do it for a short term is palliative and for to get immediate response. For a person who has a relatively good prognosis, we don't use it because the long-term control is 60% versus 80% at a year. So for a person who has a better prognosis, we do a long course, which is 10 fractions done Monday through Friday generally. There's stereotactic radiation therapy, which is a high-dose hypofractionated radiation, which is very effective in the right patient. So let's talk about steroids. How much steroids should you use? The answer is, I have read so much literature about this and even I don't know. There is no optimal dose. There truly isn't. But my general rule of thumb is that the worse the symptoms, the higher the dose of steroids I give. The reason is that we're medical oncologists. We know internal medicine. The worst side effect of a couple of days of high-dose steroids is the patient is jittery and their glucose is out of control. Both are things that we can deal with. However, long-term, having irreversible neurologic damage is worse than having high glucose for a few days. In the Patchell study, the patients received 96 milligrams per day in divided doses until they went to the operating room. The next topic I'm going to talk about is cardiac tamponade. So although we're oncologists, we have to go back to some of our internal medicine in order to understand what the mechanism of tamponade is. So embryologically, the heart is like a fist, a muscle that's pushed into a balloon, which is the serosal surfaces, and the serosal surface folds back on itself. That's what the pericardium is. And serosal surfaces secrete serosal fluid, serous fluid, and the purpose of them is to decrease the friction of a moving organ. The heart is a moving organ. Your heart beats thousands of times every day, billions of times during your life. And if you didn't have the parietal and peritoneal, the two layers of the pericardium with fluid in between them, you would have a high friction and heat. So this decreases or gets rid of the friction of the beating heart. In addition, the heart itself has a high pressure and a low pressure side. The right side of the heart is a low pressure side. The blood comes in from the venous system and is pushed through in a low pressure way to the lungs where it's aerated. The left side of the heart, on the other hand, is a very high pressure system because it's pushing the oxygenated blood out against the full systemic resistance. So you have a very muscular left side of the heart and a very flabby, kind of low flow side in the right side of the heart. In addition, your stroke volume times your heart rate equals your cardiac output, and you will try to maintain your cardiac output however you can. So what happens when you have cancer is that you can have metastasis to the serosal surfaces of the heart. So what happens is that when serosal surfaces have implants, they become irritated. And the only thing that serosal surfaces know how to do is produce fluid. So that's what they do when they're irritated. They produce fluid. And that fluid is accumulated in the pericardium, which is the sac between the two serosal surfaces that surround the heart. Now what happens is that as the pericardium fills up with fluid, there becomes more pressure there than in the right side of the heart. The right side of the heart collapses first because it's the low pressure side. And indeed, on echocardiogram, this is the pathognomonic finding of tamponade, is right ventricular collapse. However, before that happens, your body is going to try to maintain your cardiac output. But because the stroke volume is getting smaller, your heart rate is going to go up. So you have tachycardia and hypotension as symptoms of tamponade. One of the things that you see when you're trying to diagnose tamponade is a water bottle heart. This patient has a great big heart because that's all pericardium. The CT scan of that person below shows the white arrow is pointing at all the fluid that's in the pericardium. The symptoms of tamponade are very, very subtle. Shortness of breath, dyspnea, lack of energy because they're in a low flow state. And some patients actually present as anxiety attacks. It's very unusual, but if you have a previously perfectly rational patient who all of a sudden is suffering from anxiety attacks, sometimes it could be tamponade. The signs of tamponade are tachycardia, hypotension, pulsus paradoxus, which we almost never see anymore because we don't do manual blood pressures. There's a difference with inspiration of over 15% in the systolic, in the diastolic pressure. Electrical alternans can be seen on the EKG, and altered mentation is a late sign of tamponade, and by the time you've gotten there, you really need to be active. The diagnosis of tamponade is made by echocardiogram. It's like the only time that you get a result back from the echocardiogram right away. You get a call from the cardiologist or the cardiology fellow telling you what the results are. Once you have the diagnosis, you need to treat it, and the treatment is drainage. Now, who drains it is up to your hospital. So it can be cardiothoracic surgery, it can be interventional radiology, or cardiology. Somebody needs to put a tube into the pericardium and drain the fluid. While you're waiting for them to show up, you can give the patients fluids because that gives them a little bit of a bounce to their cardiac output, but it only buys you a very little bit of time. You really need drainage. Next, I'm going to talk about superior vena cava syndrome. Superior vena cava syndrome happens when there's obstruction to the vena cava. Vena cava is a really thin-walled and low-pressure venous structure that's in the bony section of your chest. Everything that surrounds it is stronger than the vena cava. You have all your arterial structures, you have bones. All of those are relatively inflexible, while the vena cava is weak. So you have prevention of venous return to the heart by an obstructive lesion, and usually the onset of symptoms is gradual and insidious. The causes of superior vena cava are predominantly lung cancer, that's the most common, but lymphoma, unknown primaries, and other tumors can be causes of superior vena cava syndrome. Be aware that up to 11% of superior vena cava syndrome is actually caused by things that are not cancer, the most common of which is clots. Tuberculosis is an old cause, and supposedly syphilis, although I've never seen it. The symptoms of superior vena cava syndrome are dyspnea in a majority of patients, facial swelling or head fullness. Many of them have a dry, recurrent cough that's very bothersome. Arm swelling is common. Chest pain and dysphagia happen, but they're relatively uncommon. The findings on physical exam are venous distension in the neck, venous distension in the chest wall, facial edema, cyanosis, plethora, which is that big red face, and edema of the arms. This is your classic chest x-ray, which is somebody who has lung cancer. You can see that they're rail thin, they have lots of bulla, they have depressed diaphragm, and probably they have, increased AP diameter, and they have a mass in the right side of their chest. This is a CT scan that shows a big mass causing obstruction of the venous structures. This is a picture that I wanted to show both because it's just an unbelievable picture of cyanosis and swelling, but also because this person has superior vena cava syndrome that is so bad that he was intubated for it, but it was not from a malignant cause. This man had Crohn's disease, and he developed a blood clot behind his portacath. So the treatment of superior vena cava syndrome is to treat the tumor. Steroids only work if the tumor is sensitive to steroids. So for a lymphoma, you'll get some results from steroids, but for lung cancer, probably not. Radiation therapy is the treatment of choice, along with systemic treatment of the tumor. Let's talk about the last of the mass effect problems, and that's increased intracranial pressure. So this is one of my patients. She was driving in Miami. She drove herself to clinic with this CT scan, and I suspect that she was probably a better driver than most people in Miami. So what you see here obviously is a very large mass in her brain. There's significant swelling. That's what all the black parts are, and you can see that she has a herniation of her falx. So it's important to remember that the most common brain tumor in adults is a metastasis. This is one of those questions they always ask you on the boards. The most common brain tumor in a child is a primary posterior fossa tumor, but in an adult it is a metastatic lesion. So the treatment is radiation therapy, surgery, and steroids. You should always ask the neurosurgeons to come by and look. Some patients are obviously excellent candidates for surgery and other patients are not. Patients who have cerebellar lesions do incredibly well with surgery, and they almost always go for surgery. And then there are other patients who are good candidates for surgery. Radiation therapy needs to be given whether or not patients have surgery or not, and steroids are incredibly helpful in decreasing the symptoms. So in the short run, start the patients on steroids while you're organizing the surgery and the radiation. So let's move on to the evil humors, and that's hypercalcemia. You all remember hypercalcemia: moans, bones, thrones, groans, stones. Symptoms are lethargy, mental status changes, frequent urination, thirst, constipation, bone pain. The causes are increased skeletal release, increased GI absorption, and decreased renal excretion. Usually you have at least 2 of these and oftentimes 3 of them. It is seldom that you have just one of these as the mechanism of action of hypercalcemia. So the etiologic factors that are associated with the cancer-related hypercalcemias are PTH-like factors, transforming growth factor, prostaglandins, calcitriol, interleukin, tumor necrosis factor, platelet-derived growth factor, and vitamin D. The malignant tumors that cause hypercalcemia can kind of be grouped into different categories based on the mechanism of action of their hypercalcemia. So the tumors that secrete PTH and the PTH-like analogs are the squamous cell carcinomas. Squamous cell carcinoma of the lung, head and neck, cervix, esophagus, they all have problems with PTH and hypercalcemia. Renal cell cancer secretes PTH because PTH is made in the kidney. The ovary, bladder, pheochromocytomas, and islet cell tumors are all in the group that have PTH or PTH-like analogs as the cause of their hypercalcemia. Bone turnover is found in myeloma, breast cancer, Hodgkin's disease, and lung cancer. So the calcitriol, elevated calcitriol levels are the etiology of action in both Hodgkin's and non-Hodgkin's lymphoma, and increase in the interleukins are specifically seen with the T-cell leukemias and in non-Hodgkin's lymphomas. Remember, there are multiple non-malignant causes of hypercalcemia, and even in patients with cancer, it is not always their cancer that's causing their hypercalcemia. And I have to say that at least 2 or 3 times every year, one of my breast cancer patients in remission is found to be hypercalcemic by their primary care physician, told that they have a relapse and are sent to me, and what they really have is primary hyperparathyroidism. Primary hyperparathyroidism is the most common non-malignant cause of hypercalcemia, and please remember this. Hyperthyroidism is the cause of hypercalcemia. Lithium used to be a frequent cause of hypercalcemia, but as the psychiatrists have gotten away from lithium use, we don't see it that often. Familial hypercalcemia, I have to say that if you're making the diagnosis, it's probably wrong, because these people are diagnosed as children with this, and if by the time they're an adult you're diagnosing it, it just doesn't make too much sense. Tuberculosis is frequently associated with hypercalcemia. Coccidiomycosis, probably if you live in places that have coccidio. We don't have a whole lot of it here in Miami. Thiazide diuretics have become very popular in the past 10 years, and so it is a frequent cause of hypercalcemia. Sarcoidosis, renal insufficiency, berylliosis, which I also have never seen, but it's in the list, so I put it there. Vitamin A and D intoxication, as well as calcium supplements and milk alkali syndrome, are all things caused by our patients trying to make themselves better by taking vitamins and instead making themselves worse. The treatment of malignant hypercalcemia is to treat the tumor. The first thing you do is you give patients lots of fluids, normal saline. By the time they come to us and are symptomatic, they're usually missing approximately 6 liters of normal saline. So give them 5 or 6 liters of normal saline and then start to worry about keeping their I's and their O's equal. The use of diuretics, specifically Lasix, which is a calciuric agent, are done more because you need to keep the fluids balanced rather than that Lasix is a really good calciuric agent. Use steroids if the tumor is sensitive to steroids. So the lymphomas that are associated with hypercalcemia, they respond to steroids. However, prostate cancer probably doesn't. Bisphosphonates are the standard long-term treatment for hypercalcemia. Please do not give full dose bisphosphonates to somebody when they first come into the hospital with their hypercalcemia. This happens relatively often and can lead to really profound and prolonged hypocalcemia. The dose of bisphosphonates has to be adjusted for renal function, and it's best to improve the renal function with fluids until you get it stabilized before you give them their first dose of bisphosphonates. Calcitonin can be used, but remember, calcitonin just buys you time, and there's tachyphylaxis to it. So do not use calcitonin unless you have a second line of treatment planned.